Good morning. Welcome to Shining a Light on Alcohol Use Disorder Through the Eyes of the Patient, improving recognition and management. Appreciate everyone who's joined us here in person at the American Academy of Addiction Psychiatry Conference, and I appreciate everyone who is visiting us online. Please use your own technology. This is an interactive experience, so on your personal device, using this QR code, you can view the slides, access today's content, ask questions, and participate in polling. The Wi-Fi for those that are here in person is posted here on the slide. All right, so. Can you make that appear again? Yes, I will make that appear one more time, and we will put up the QR code for just another moment. All right, so with that, we will move forward. Shining a light on alcohol use disorder through the eyes of the patient. I'm Brian. I'm your moderator. I'm an addiction psychiatrist, and I work for the LA County Department of Public Health. I am also, full disclosure, the immediate past president of the American Society of Addiction Medicine, so I'm not unbiased with respect to ASAM. I'm joined here by Alyssa and Tauhid. Alyssa?
Hi, good morning, everyone. So happy to be here. My name is Alyssa Peterkin, and I am faculty at Boston Medical Center. I'm an internist and addiction medicine specialist. So thank you all so much for joining us today.
Good morning, everyone. My name is Tauhid Zaman. I am an addiction psychiatrist. I'm based at the San Francisco VA, where I lead the addiction consult service. And in my educational role, I'm program director of our UCSF Addiction Psychiatry Fellowship. So glad to be here with you.
All right. So our agenda for our time here together is the welcome and introductions, which I've almost finished. Then Alyssa is going to jump into starting the conversation in working with people who might have a problematic relationship with alcohol. I'm going to be talking about non-pharmacologic approaches to working with people with alcohol use disorder. And then Tauhid will wrap us up with interventions for alcohol use disorder, and we'll take questions through the app. So if you have a question or a comment, please use the interactive, I'm going to say the app, the QR code is the way you can get questions to our panelists. So polling question number one. How confident are you in your ability to apply evidence or guideline-based pharmacotherapies when developing a comprehensive treatment plan for patients with AUD? So I'll just repeat that one more time. How confident are you in your ability to apply guideline-based pharmacotherapies when developing a comprehensive treatment plan for patients with AUD? 1, not confident at all, to 5, very confident. Just give that, I'll let that sit for a moment. All right. The next polling question. How confident are you in your ability to apply guideline-based psychosocial interventions when developing a comprehensive treatment plan for patients with AUD? These are non-medication strategies. So I'll repeat that one more time. How confident are you in your ability to apply guideline-based psychosocial interventions when developing a comprehensive treatment plan for patients with AUD? 1 to 5, 1 being not confident, 5 being very confident. So I'll give that another moment. All right. So we have a range. Excellent, excellent. Okay, so I will turn it over to Alyssa, starting the conversation in alcohol use disorder.
Thank you, Brian. All right, so we're gonna actually kick it off with a video.
So what brings you in today?
I don't know. My family told me to come here. They think I drink too much, but they're overreacting.
So your relationship with alcohol is just fine, and you don't know why people would be worried about you.
Yeah. I mean, yes, I did get one DUI, but it was totally dumb. And I think the breathalyzer was broken, honestly.
So you had some bad luck.
Yeah.
And your family is worried that your relationship with alcohol led to the DUI.
Yes, exactly. I don't have a drinking problem.
So your drinking is totally normal.
Yes, like very normal. I have a couple of drinks after work and more on the weekends, but that's pretty much everyone in my situation.
Okay. So tell me about how much you drink.
I drink 3-ish after work, depending on how long we stay at the bar. More on the weekends, but normally not more than like 5 or 6, unless it's a special occasion. Sometimes 1 or 2 at a power lunch with my coworkers, but we haven't had time for that lately.
So you drink wine or beer?
Cocktails, usually. Wine if it's daytime.
Got it. So wine at lunch and
Mhm.
cocktails in the evening. You like to unwind after work.
Well, after work, I like to go to bars and clubs, that kind of thing.
Have you noticed yourself feeling tired before work or wondering what you did the night before? Anything like that?
It depends, honestly. If I'm out late seeing a bunch of friends and, dancing, I'm obviously not going to remember every conversation. I get insomnia, so I just stay out until I'm tired or I won't actually sleep.
So is it that you can't get to sleep?
No, I wake up a lot throughout the night.
So you stay out at bars and clubs so you can sleep better when you get home.
Yeah. I mean, it's really the only places that are open late.
So what do you know about the connection between drinking alcohol and staying asleep overnight?
I've heard it makes it harder to stay asleep.
And with your sleep trouble in mind, would it be okay if we discuss your drinking less alcohol to help you sleep better?
I guess so.
Okay, so we're going to continue this case as we go through our time this morning. But I want you to think about some of the pieces of that patient's story that stood out to you as we move on to some of the slides. So I always like to, in my teaching, tell people that alcohol use disorder is a complex condition. It is not a moral failing, and there are several risk factors that play into whether or not someone may develop an alcohol use disorder. Genetics is a big part. It can account for 50%. And other things I wanted to highlight is, adolescence is a risky time. It's often a time where people will try drugs and alcohol for the first time. But we also know that individuals who are exposed to drugs before the age 18, 90% of them are more likely to go on to develop a substance use disorder. And for individuals who try alcohol or drugs before the age of 15, they are nearly 6.5 to 7 times more likely to develop a substance use disorder compared to someone who delays their use until age 21. And we know that the brain is still developing, right, up until the age of 21. And so our early substance use in life, alcohol use or any drug use, impacts the development of the brain and can lead to more sort of impulsivity and impulsive substance use. And then, we can't forget about trauma. Adverse childhood experiences also play a role in increasing the risk of someone developing an alcohol use disorder. And right, we also know that there are some individuals who drink heavily or engage in binge drinking patterns that then go on to develop alcohol use disorder. And talking to a group of psychiatrists, I'm sure you all are aware that there is a huge overlap, right? Co-occurring mental health conditions, anxiety, depression, PTSD, and sometimes people are drinking to self-medicate and treat some of these conditions. And as a reminder, alcohol use occurs on a spectrum, right? Not everybody who drinks alcohol has an alcohol use disorder. There are some individuals who actually do not drink at all, right? So they have no consumption and no consequences. And then you move up in this pyramid and there's another subset of individuals who have low risk drinking. So they're not, exceeding what we would say drinking guidelines. And then at the top, so about the third of the pyramid, these are the individuals that we are most concerned about, right? Individuals who have risky or unhealthy alcohol use, so exceeding 4 or 5 drinks in a setting or 7 to 14 in a week. And then at the very top, we have individuals who meet criteria for alcohol use disorder. And based on the most recent national survey, drug use and health results in the United States, that's about 27 million people over the age of 12. So that's a substantial amount of individuals. And again, we'll go over the exact criteria for alcohol use disorder, but I like to think of it as a uncontrolled compulsive use despite negative consequences. And right, with the DSM-5, that term has replaced the terms alcohol abuse and alcohol dependence. Okay, and screening is so important. So we should screen everyone. This reduces bias. And we should follow up a positive screen with a formal assessment using the DSM-5 to make a diagnosis of alcohol use disorder or rule in, rule out. And here is the DSM-5. And so individuals who meet criteria for alcohol use disorder have to meet at least 2 criteria. So there are 11 total. And on this slide, I've sort of grouped them into different categories, right? So impaired control, social impairment, risky use, and physiologic effects of alcohol. And if we think back to our patient, this person was continuing to drink, which results in physically dangerous situations, right? The DUI. And also there was a lot of themes of the impacts that this person's alcohol use was having on the relationship with their family. So jumping closer to criteria 6. So just highlighting a few, I'm sure there are many more that this individual met as well. And then I'm going to talk about screening. So there are a lot of different screening tools that are available. I'm going to talk about some of the more common screening tools. And these are particularly for adults, but for special populations, there are screening tools. So you can think about special populations of pregnant people, adolescents, and older adults. But we're going to focus on 3 specific screening tools today. And I'll start with my favorite because it's the simplest one, right? The single item screening question, which is 1 question. How many times in the past year have you had 5 drinks? So if this is someone assigned male at birth under the age of 65, or 4 for someone assigned male at birth over the age of 65 or woman in a day. So any answer other than 0 or none is considered a positive screen. And so this has 80% sensitivity and specificity for unhealthy alcohol use. Before I usually ask this question, I say, do you drink alcohol? It's probably a good place to start. And then I proceed with the single item question. Then there is the audit C. So the alcohol use disorder identification tests, and these are the consumption-based questions. So these are 3 questions out of the audit, which is a 10 question screening tool, which will be on the next slide. But a score of 3 for anyone, for women, 3 or more, or 4 or more for men is considered a positive result for unhealthy alcohol use. A higher number, 7 to 10, is suggestive of moderate use disorder. Again, with these results would follow up with the DSM-5 for formal diagnosis of alcohol use disorder. And then here we have the audit. So that's 10 questions. The max score is 40. And you can see on the top here is the audit C, the 3 consumption-based questions, followed by the remaining 7. And a score of 8 here indicates unhealthy alcohol use, and 15 or more indicates a moderate or severe alcohol use disorder. And now I want to talk about assessing for comorbid conditions. So as I said, I'm an internist. I'm actually a hospitalist. So I spend a lot of time in the hospital taking care of people who are admitted for medical and surgical complications related to their alcohol use. And I also do addiction consults, so have seen sort of the full spectrum. And I thought it would be helpful for us to center this discussion by looking at the leading causes of alcohol-related deaths in the United States. So this data comes from a 2024 CDC paper where they compared alcohol-related deaths between the years of 2016 to 2017. and 2020 to 2021. And first and foremost, they noted a 29% increase overall in deaths, and they broke it down by chronic and acute conditions. So leading was heart disease and stroke. So we're talking about atrial fibrillation, coronary artery disease, ischemic and hemorrhagic strokes. So 37,000 folks there. And then cancers, so many different types of cancer. Breast cancer for female, we have oral cancer, esophageal, laryngeal, pharyngeal, liver, stomach, prostate cancer for men, as well as pancreatic cancer. And then looking at, liver and gallbladder and pancreatic diseases, a lot of the sequelae associated with cirrhosis, so portal hypertension, esophageal varices, just to name a few. And then for the acute conditions, alcohol-related poisonings and drug overdoses were leading charge. So, alcohol was involved with other drugs, leading to people, dying from an alcohol-related death. And then there were motor vehicle accidents, but not just motor vehicle accidents, but drownings and falls that were associated with alcohol use. And then suicide was also another very common cause of death in this group. And so either alcohol was fully or partially involved in these cases. And so if we think about how can we screen for some of these conditions, right? Blood pressure, right? We know that there's an association between hypertension and alcohol use, but not just saying, oh, your blood pressure is high, it's because you're drinking. If people are going to continue to drink, we have to manage their blood pressure too. And, screening for hyperlipidemia, doing an A1C, like these are things that can contribute to coronary artery disease and stroke. So again, right, they might have alcohol use, but they're likely going to have other risk factors. So how can we address those as well? And then making sure people who are using alcohol either unhealthily or have an alcohol use disorder are up to date on their age-appropriate cancer screening. So that can be mammograms, colonoscopies, or fecal immunochemical testing. And then thinking about, liver and gallbladder, pancreas conditions, hepatitis, right? Hepatitis B, C, screening for those, offering treatment. Treatment is so much more affordable, so much more accessible, and much more tolerable than it had been for a long time ago. And you don't have to wait for people to stop using to treat them. And right, again, if alcohol is going to impact their liver, you want to try and avoid other causes as well, right, that can lead to cirrhosis or hepatocellular cancer. And then liver function tests or fibroscan. So these are sort of non-invasive tests. Other scores, there is a FIB4, or the APRI test, which is the aspartate aminotransferase to platelet ratio. And these, again, are assessments of fibrosis and liver stiffness. So another tool you can help you understand the impact of alcohol might be having on the patient's body, but also something to talk with your patient about. And so just going to highlight some of the other tools we have. So the PHQ-9 screening for depression, right? There's a huge overlap, right? 27 to 40% lifetime prevalence for people with alcohol use disorder will also have major depression. And so a score of 10 or more indicates likely depression. So this is a tool that can be used when patients are waiting in the waiting room or before they come to your visit. And again, another way that you can intervene to help reduce some of the comorbid conditions associated with alcohol use. And then there's a shorter version, so the PHQ, it's less PHQ-2, less specific than the PHQ-9, but shorter. And so, right, if this is negative, you can stop there, but if if there's concern, they can move on to the longer screening tool. And then there's the GAD-7. So again, another overlap between anxiety disorders and alcohol use disorder. Which one came first? Sometimes we don't know. But if someone does have an anxiety disorder, it would be helpful to intervene because that can also potentially address their alcohol use. And the U.S. Preventive Task Force actually recommends that we screen folks on an annual basis anyway, so all adults. And then just wanted to highlight avoiding alcohol poisoning and drug overdose, right? So you should be screening for other substances as well. And if someone has a substance use disorder, treating that. And if you're worried that your patient might be intentionally or accidentally exposed to opioids, prescribing naloxone. A lot of my patients use alcohol and cocaine together, and cocaine is often contaminated with fentanyl. So offering naloxone can help, save a life in case someone does experience a drug overdose. And safer use strategies, right? Eating before you start drinking, alternating with water and alcohol, consuming beers instead of shots or other liquors which have higher alcohol content, which are typically ingested faster, socializing with people who don't drink. And avoid mixing alcohol with benzos or other sedatives and drinking at your own pace. So not doing those rounds and shots, and avoiding your phone and social media for a variety of reasons while you're drinking. Another way for to keep you safe when you are drinking alcohol. And this is a tool that you can use to screen for other substances, the TAPS one. And so for any answer other than never, that's a positive result. And you should follow that up with the TAPS 2 or the DSM-5. The TAPS 2 is much more comprehensive. It gets into how many cigarettes are you smoking, like all those sort of nuanced details. But this is another way that you can screen for other substance use in your patients with alcohol use disorder. And then PTSD and alcohol use disorder, huge overlap, right? 15 to 30% of people with alcohol use disorder might also have co-occurring PTSD. And that number is even higher in the veteran population, right? So there are a few screening tools here. So there's a primary care PTSD screen. And this is for people who probably have PTSD. If you are, taking care of veterans or military personnel, I would probably go straight to this tool. It not only can help you determine if someone has PTSD, you can also look at the symptom severity over time. So it's a good tool for sort of monitoring how people are doing. So it's 20 questions. So that's where I will end there. So just wanted to highlight alcohol use occurs on a spectrum. Greet everyone. Pick one tool, right? There are many of them. They have various sensitivities and specificity, but the best thing you can do is screen your patients. And for those who have a positive screen, do a formal assessment to rule in and rule out an alcohol use disorder. And remember that alcohol use impacts the physical, mental health, and well-being. So screening for those co-occurring conditions can help save lives and reduce the morbidity and mortality of alcohol use. And so I'm coming to the conclusion of my section. And so before I turn it over, just want you to think, in your own clinical setting, what changes can you make to better initiate a conversation for patients about their unhealthy or problematic alcohol use? All right, got to turn it back over to you, Brian.
Thank you. All right. This next section talks about non-pharmacologic approaches to working with patients with alcohol use disorder. Actually, to start, we'll go back to the video.
A few different types of talk therapy have been shown to help reduce drinking, and it has the added benefit of helping with other areas of your life. So for example, if your insomnia were related to something else like anxiety, psychotherapy can also help with that.
Maybe.
And one added benefit of psychotherapy would be your family might be less on your case.
Oh yeah. I don't know that I really feel like I need it, but yeah, I would definitely get them off my back.
Maybe something to consider, if only to reassure your relatives.
Yeah, it's a thought.
And you might also consider family therapy. If you think this fear on their part has more to do with your family than with your drinking.
Honestly, they're pretty close-minded. I don't think they would come to therapy.
No problem. Well, like you said, you're comfortable with your relationship with alcohol. And if you did want to talk about your relationship with alcohol further, there are also groups where you can discuss this with other people that might share your goals.
Oh, no, no, thanks. Those are for serious alcoholics and not for working professionals who got one DUI.
You'd have to have more problems before you consider attending a group.
Yeah. I don't think groups are for me right now.
Okay, no problem.
All right. One of the biggest public health threats to working with people with alcohol use disorder is just how few people with alcohol use disorder are in any kind of treatment. If you look at the National Survey on Drug Use and Health, between 85 to 95% of people with alcohol problems are not receiving treatment for their alcohol use disorder. So part of the psychosocial approach in working with people with a problematic relationship with alcohol is not setting the bar so high to start treatment. So when I talk with people about their relationship with alcohol, I don't start the question, are you fully committed to full sustained abstinence from alcohol today, forever forward, because then I will start working with you in order to help you get ready to enter full sustained remission from alcohol use. Like we can't set the bar so high if you decided to stop before we work with people that might consider whether they're ready to stop. So let me be clear about what I'm saying here. The safest relationship that people can have with alcohol is one of abstinence. That's the safest. And not everyone is there. So when I talk with people about alcohol use, I say, what changes have you been thinking about making? Are you thinking about increasing your drinking? Decreasing your drinking? Staying about the same? How are you thinking about this? Because it opens up a broad conversation around the person's ideas, their goals, and their values. Now, when somebody says, Doc, I am sick and tired of being sick and tired. I need help and I need to stop. Great, let's work on that. But that's a goal that I've gotten from them, not a goal I'm setting for them. Even if it's something I think is true, and I'll be straightforward. And I think the safest thing you can do with respect to alcohol is to stop. I don't necessarily insist that that is the only goal that we can work on. And part of the rationale for that is certainly people with alcohol use disorder have impaired control and social consequences and physiologic risk, right? There's a whole, we understand that that is part of the condition. But reduced drinking does see benefits on the addiction severity index. You see reduced physical and psychiatric risks with reduced drinking. I'm not saying reduced drinking is the only goal, but I'm saying for some people that may be where they are. And it is much more important for to stay engaged with somebody than it is for me to try to leverage my relationship such that if they're not on board with abstinence, that they walk away, right? It is always better for somebody to be engaged in treatment than it is for them to be entirely out of care. Because most people we work with alcohol use disorder are ambivalent about whether or not they should stop. On one hand, I would get my family off my back. I would have much lower risk or no risk of getting another DUI. There would be all these benefits. But on the other hand, the relationship that people with alcohol is oftentimes complicated. They find alcohol helpful in a number of circumstances, right? In some ways, alcohol is a solution for them. It's a solution that causes problems. Let me be clear about that, right? But it's nonetheless, it's something that they have found helpful. And ambivalence is actually a normal part of the human experience. I don't know how many of you eat exactly the nutrition that you're supposed to and get all the recommended exercise in accordance with national guidelines. So you may think about your own ambivalence around a number of behaviors. Particularly with alcohol use disorder, we see a similar pattern of ambivalence, thinking and feeling two different ways. On one hand, the alcohol helps with this. On the other hand, it hurts with that is actually a very normal experience. So when we start the conversation around where are we going, it's really helpful to understand where are we going from the patient's perspective, their ideas, their values, their goals, their preferences. So someone comes in and says, hey, I need to stop drinking. I'm done with alcohol. Okay, I kind of know where we're going and the focus is clear, right? Tawhid will talk about additional therapeutic approaches, but like withdrawal management and early stabilization, and there's a bunch of stuff that we can do when the goal is clear. But for many people, that's not exactly where they're starting, right? They might be starting with, well, I don't know that I need to change anything, but if I did, maybe I could drink less, see how that works. There's a few different options that we can work with people on, right? Medication approaches, non-medication approaches. This is the non-medication section of this talk. And so that's agenda mapping, choosing a path. Or somebody's like, hey, I'm just here because my family got me here. I don't even know why I'm here, really. You know what I mean? Like, I just, here we are. Okay, we actually need more information. I need to clarify where we're at in terms of somebody's readiness to do anything in terms of making a change. And we tend to think about talking with somebody about reduced to drinking and talking with somebody about stopping drinking are completely separate conversations, right? Are completely separate conversations. If I talk with somebody anything other than full sustained abstinence, then somehow I'm not giving them the full benefit of care. And it's a problem from my vantage point to consider abstinence-focused goal setting and reduced substance use to focused goal setting as somehow fighting with each other. I do not think these concepts need to fight with each other, because people come into and out of readiness all the time. People come into and out of a commitment to abstinence all the time. That is a normal part of ambivalence and a normal part of the human experience. So I'm saying two things at the same time. If and when people are ready to commit to stop drinking, fantastic, capitalize on it. We support that because it is the safest thing, particularly for patients with alcohol use disorder. But people with alcohol problems actually are well supported by either at any given time. And it's the engagement is prerequisite. The fact that we are engaged in a conversation with people where we can continue to work with them is the foundation for anything else that comes. So focus on engagement, even if the person's not on board with full sustained abstinence, is sort of the recommended approach. When we do talk therapy, psychosocial therapy, when we do treatment, there's a lot of words. Many words have come out of the language our culture uses to describe addiction. Many of those words that have been repurposed by community self-help groups, where we use words like clean to describe abstinence, or alcoholic or addict to describe person with alcohol use disorder, person with a non-alcohol substance use disorder. And the issue with this is when people have an active substance use disorder, I would never, as a psychiatrist, or I would never recommend a clinician describe somebody as dirty. That's kind of pejorative from my vantage point and can actually distance people. That's a relationship distancing term. So why would I use the word clean? Even though people use it all the time, we hear it all the time working in addiction care. But the words we use reflect how we think, and how we think reflects how we act. So I'm influenced by the research looking at the implicit bias association testing. What do we know about the words that we use when we talk with people about substance use disorders, right? And what we find, if we use the word like alcoholic, right? So Mary is a white woman who's completed college. She's a serious alcoholic, but she managed to get through the challenge she faced as a recovering alcoholic. She lives with her family and enjoys spending time outdoors and taking part in various activities in her community. She works at a local store. Whereas Mary is a woman who's completed college. She's also has an alcohol use disorder, but has managed to get through the challenge she faced. As a woman in recovery, she's lived with her family. Just that one phrase tends to change how people think about Mary. The words we use do then have a baggage around them that invokes a lot of social frames. So words like alcoholic or addict, people tend to think, this person has a fair amount of willful misbehavior, we need to punish them. Versus person with alcohol use disorder, this person has a condition and they need help, right? They are different frames that those terms invoke. So consider, this is somebody who uses alcohol. There's a recurrence of use. I don't use the word medication-assisted treatment because it's weird. We don't call antidepressants any medication-assisted cognitive behavioral therapy. We don't call insulin medication-assisted diet and exercise. Antidepressants treat depression. Insulin treats diabetes. Meds for alcohol use disorder treat alcohol use disorder, right? Like these are treatments. We call them addiction medications. And then person with alcohol use disorder would be kind of the preferred person first language. So a couple considerations. Avoid labeling. Use neutral terms that support the relationship we have, and as medical clinicians, our relationship with people as medical clinicians, right? So alcohol abuser, alcoholic, what we know from the implicit bias research, people are less perceived to be less likely to benefit from treatment, more likely to benefit from punishment, more likely to be socially threatening, more likely to be blamed. ASAM, the American Society of Addiction Medicine, and as you know, I'm on the board of ASAM, so I'm not unbiased with respect to this, got a grant from the LA County Department of Health, or not LA County, California Department of Healthcare Services, not who I don't work for. And DHCS said, you know, one of the things we're running into with publicly supported substance use treatment is that people are oftentimes denied admission to substance use treatment program when they exhibit the symptoms for the very condition that they need to be in substance use treatment for, right? It's sort of the catch-22. Like if you use, you can't, if you've used with the past 24 hours, you can't be here, right? Well, you know, we can't set up this sort of high barrier to entry. We're not treating nearly enough folks with alcohol and other substance use disorders. So there's this document, Engagement and Retention of Non-Abstinent Patients in Substance Use Treatment, Clinical Considerations for Addiction Treatment Providers, designed to address what should substance use treatment look like? And it starts with trust building, a warm, trauma-informed, non-judgmental environment that will talk with people where they are and does not require abstinence before we have a conversation with somebody. Now, let me be clear. Residential substance use programs are almost universally abstinence-based settings. People don't drink when they're in residential. They don't use when they're in residential. And that has not changed. But to at least have a conversation with somebody about what would be possible, our door should be wide open to having those conversations around what somebody might be ready for. Because I will tell you, I send patients to residential. Many people that go there, they'll not use while they're there, but they haven't necessarily decided that they've decided they're going to not use the rest of their lives. In some ways, that's a period of time for them to trial abstinence, see how it goes, get some containment, get some support. So don't require abstinence as a condition of starting that conversation. Tailor clinical approaches that boost participation and retention. If somebody storms off, goes on relapses, reach out. How you doing? What happened? How can we be helpful? Administrative discharges are sometimes necessary, right? When somebody's not adhering to program requirements or threatening, the patients or other staff. But we should use administrative discharge as a last resort, not a, oh, well, you didn't wake up on time, go to this group. You clearly are not serious about your recovery. You got to go, right? Use administrative, sometimes they're necessary, but they're really a last resort. And when people leave, and people leave treatment all the time, that we actively seek to try to re-engage them. And that's on the discharge end. I actually think in substance use treatment, our doors need to be wide open. Build links to individuals who are not in treatment. Work with harm reduction and service programs. Support engaging people in the community in settings where people aren't necessarily in treatment. And none of this works if you don't have staff that can actually pull it off. So everyone that I talk to usually reads these and nods, oh yeah, this is good stuff, yeah, okay. But if it doesn't then translate to your front desk person or the security guard that's standing outside of where you work, or the other staff that are participating in the patient flow, oftentimes you'll find people get turned away before you even know it. And you can't get staff buy-in when you're replacing your staff every 90 days because of all this staff turnover. So it means paying people a living wage, prioritizing frontline staff satisfaction and retention. That also means developing financial models where it's more attractive to work in substance use treatment than it is in retail, right? Which is oftentimes on a wage basis an alternative for a lot of frontline people that work in the substance use field. And make sure that the policies and procedures include all patients, including patients who are not abstinent, and measure outcomes and continuous engagement and retention. Many of you probably have heard of 12 steps. These are the 10 steps of engagement and retention of non-abstinent patients in substance use treatment. So in substance use treatment, we have medications, counseling, and support. This is the triad of behavioral medicine. The treatment for depression is medications, counseling, support. Treatment for hypertension is med, diet, and exercise. The treatment for diabetes is med, diet, and exercise. So this triad exists in a number of fields where our behavior interacts with our health conditions. For us to deliver the meds and counseling support, we need a multidisciplinary team. Right? It's generally not one practitioner who's supporting all of this. And that means working with licensed clinicians or counselors that are trained in psychotherapies. And so the psychotherapies that have been called out by SAMHSA now for a while include 12-step facilitation therapy, cognitive behavioral therapy, motivational enhancement therapy, community reinforcement, contingency management, multi-systemic therapy, multidimensional family therapy. And this is typically where I ask, which of these is best? Which of these is best? And Project Match actually went to try to go answer that. Right? So Project Match compared cognitive behavioral therapy to motivational enhancement therapy to 12-step facilitation therapy. And the answer is, it's the one the patient takes. What's the right therapy? It's the one the patient does, right? So there were reductions. Anyone who got therapy, regardless of modality, reduced their drinking. Now, there was not one psychotherapy that outperformed any other for substance use treatment outcomes. So being in therapy was the biggest effect. So when I say focus on engagement, that's what I mean, right? Like work with people in the context of their lives, because when people leave, they do worse, right? So we know from Project Match. There's a Cochrane review that came out that looked at the efficacy of 12-step programs on reducing alcohol consumption and found that 12-step facilitation therapy outperformed other forms of psychotherapy with respect to alcohol abstinence. I think it's worth actually taking just a moment to talk about the study. And then Tawhid will actually talk about 12-step, like what is 12-step community self-help and 12-step facilitation therapy. But in the Cochrane review, they did find that, again, 12-step facilitation therapy led to more abstinence. Now, keep in mind, the 12 steps have a number of, well, there's 12 steps and a number of traditions around 12 steps. So the only requirement, according to the big book, is a desire to stop. In other words, abstinence is kind of, even not necessarily having attained abstinence, but a desire for abstinence is actually built into the 12-step approach. It's not necessarily built into motivational enhancement therapy, which can accommodate a pretty broad set of goals. Same thing with cognitive behavioral therapy. And 12-step facilitation therapy is actually clinician-delivered manualized treatment. So when you look at this clinician-delivered manualized treatment that adopts some of the principles and techniques of 12-step programs and engages people with NAA during and after treatment, we found that TSF, 12-step facilitation therapy, tended to support more people abstaining from alcohol than alternatives. High certainty evidence that clinician-delivered, this is important, and manualized 12-step facilitation programs increased AA participation with higher rates of continuous abstinence. Non-manualized 12-step programs, where you send somebody off to an AA meeting, does not always show that same response, right? There is lower quality evidence with non-manualized programs. That is to say, they're harder to study. Seems to perform just about as well as other interventions. So what's the right psychotherapy? It's the one the patient takes. It's the one that resonates with them. That absolutely includes 12-step, and it includes other treatments as well. And then there's a whole number of social supports, community supports, peer supports, so family and social connections, particularly social connections with people that don't drink. There's a pretty big hypothesis that that's one of the big drivers of the effect of 12-step community self-help, is that it connects you with people who don't drink, right? That seems to make a big difference. And there are in addition to 12-step groups, smart recovery groups, rational recovery groups. I mean, you can go on and on in terms of the list of community self-help groups. There's religious organizations and other communities that work with people to support abstinent activities, number of community organizations and intentional communities. So, in conclusion, when we're talking about psychosocial treatments for alcohol use disorder, engagement is prerequisite. The words we use reflect how we think, and how we think reflects how we act. So paying particularly attention to how do we talk about people's relationship with alcohol, and how do we talk about the people with alcohol use disorder makes a big difference to how well we're able to stay connected. The biggest driver of the treatment gap is actually a lack of people participating in treatment. It isn't necessarily that we don't have it. We've not solved access issues, like we don't always have a bed on demand at the place and time exactly when someone's ready, but the lack of access is not the big driver of the gap. It's actually the lack of supply. So being more open and engaging with people and recognizing and resisting the righting reflex. Somebody says, I have a DUI. We say, well, you need to stop drinking. Okay, let's fix it. Let's work on it together, and resisting that reflex to tell people what to do, because people are so much better convinced by their own ideas than by us. And a treatment including counseling support is a team activity. Recognize that people are surrounded by a milieu, and supporting people connection to the broader set of community supports. So in thinking about what we covered, do you have any patients with an alcohol use disorder diagnosis who may benefit from non-pharmacologic therapeutic interventions? I will let that rhetorical question sit and percolate for a moment while I pass this over to Tawhid.
I have one. Thank you.
There we are.
Thank you so much, Brian and Alyssa. So I'm going to be wrapping us up today by talking a little bit about interventions for alcohol use disorder. And this says medications at the right time, but I would say I'll be discussing some interventions beyond that as well, and hopefully leave you with a toolkit that you can bring to your patients with AUD. We're going to start off, as we have been, with a video first.
Erin, hi. Nice to see you again. Have you been?
Okay, I guess. My boyfriend and I got into a huge fight. It's been kind of tough.
Oh, I'm sorry to hear that. Well, tell me more about it.
We were fighting about drinking, of course. We don't live together, but he stays over a lot. We were having a date night.
Right.
Anyway, I thought we were having a nice time. We were tasting all of my bourbons, and I was teasing him about being a lightweight and some other stuff. I don't really remember, but it was just, dumb couple stuff.
Go on.
And the next morning, he was really mad. I guess he didn't think it was funny. He said that I always do this, and that we might need to stop seeing each other if I don't get some help. I think I want to know more about medications that could help me drink less.
I'm happy to tell you about medication options. There are a few available. Would your goal be to stop drinking completely or to reduce your intake?
I don't know. I think probably just cutting back a little bit. I'm not ready to stop drinking.
Okay. If you want, I can just give you all the options we have to help with drinking, and you can tell me what you'd like to hear more about.
Yeah, that'd be nice.
Okay, great. All right. Well, the first one I'd like to mention is naltrexone, and it reduces the rewarding effects of alcohol and can help lower cravings and help you drink less. It comes as a pill you take every day, or as an injection administered in a doctor's office or pharmacy each month.
Okay.
And next we have acamprosate, and it helps people to continue to stop drinking after they've already stopped. And the usual dose is 2 pills taken 3 times a day. Okay. And the third option is disulfiram. And this one causes unpleasant reactions if you drink while taking it. So this medication, it only makes sense when you've stopped drinking and are committed to staying stopped.
Okay.
Right. Do any of these options sound like something you'd want to try, or do you want more time to think?
I definitely need more time to think about the medications. But I think I might be ready to try therapy.
Okay. I'd be happy to refer you to a therapist.
Thanks. Maybe I can come back after I've thought about the medications for a little bit.
Of course, we can definitely get you in for a follow-up. And if any of the treatments appeal to you, I can give you more information about the potential side effects and suggested lab work.
Okay,
Okay.
thanks.
Yeah. I'll go ahead and I'll send you the therapist referral.
Okay, so in that example, we see someone kind of very consistent with what Brian has been describing, really kind of eliciting someone's own goals and then targeting therapies appropriately. And another tool that I wanted to share with you that I think can be quite useful is to think about the stages of addiction even beyond some of the diagnostic considerations that Dr. Peterkin mentioned. So beyond the diagnosis of alcohol use disorder, thinking about the stage of addiction that you are targeting can be incredibly powerful. I'm actually curious, who here in the room has encountered this diagram before at any point? Okay, this is often the case. So this has become ubiquitous, I think, in addiction training, and with good reason. So this draws upon data from George Koob at the NIAAA, who looked at basically 3 different stages of addiction through which patients cycle again and again: the binge intoxication phase, the withdrawal negative affect phase, and the preoccupation anticipation phase, what we might colloquially describe as kind of craving, perhaps. And each of these kind of stages have different neurologic correlates. So I'm not going to be talking about the neuroanatomy at this hour of the morning in detail, but I think this is really useful because you might target your intervention appropriately depending on what stage your patient is experiencing at the moment. So the management for someone who's intoxicated with alcohol might be to think about some of the safe use strategies that we talked about, watching out for accidents, watching out for co-use of other CNS depressants, safety monitoring, more kind of supportive management. When it comes to withdrawal management, you might be concerned about someone progressing to some of the autonomic issues that can develop during withdrawal, to seizures, to delirium tremens. So it's kind of a different route of treatment that you can kind of target. When people aren't acutely kind of intoxicated or in withdrawal, they can absolutely be in that preoccupation anticipation phase, which can be targeted by some of the medications that we were hearing about in that example, and we'll speak more about it. Now, this is a term that I had not encountered prior to kind of my training. This is hyperkatifia. Who has encountered hyperkatifia as a term before? Okay, I see a handful of hands. Keep me honest if this definition sounds incorrect to you, please, but this is my understanding, also from George Koob. It refers to the fact that people with addictions broadly, and certainly people with alcohol use disorders, have a heightened response to stress in the absence of their substance of choice. So this has actually been borne out in studies where we've looked at people's stress responses as measured by their cortisol levels, by their interleukins, the inflammatory markers that are in their system. And so people who have gone through these cycles again and again have a heightened stress response that has been kind of chemically proven. The reason I emphasize this for you all and with my colleagues and with my patients is that after a certain point, someone may very well be using just to cope with hyperkatifia, just to cope with the stress response, not because they want to get intoxicated, get drunk, have the euphoria, whatever it is, but just to remain functional and manage their kind of stress response. So I think this is really helpful to keep in mind and also helps destigmatize use. I'm going to speak a little bit more about the alcohol withdrawal stage. And here, what we're worried about is progression kind of down this timeline to the more kind of moderate to severe symptoms, where kind of the autonomic symptoms start to kind of kick in, and you start to worry about seizure risk and alcohol withdrawal delirium, colloquially what we call delirium tremens or DTs. I'm not going to kind of read through all the signs and symptoms. I think you're familiar with them, but I want to mention some highlights really quickly. So first of all, the timeline. Generally, moderate to severe withdrawal will start to kick in around 24 to 72 hours from someone's last drink. So that's why we always want to get that history. Withdrawal seizures can happen in a really large window between 8 to 48 hours. And then alcohol withdrawal delirium, which involves the delirium, which is waxing and waning consciousness, but also that autonomic instability that we really worry about, that can happen between 72 and 96 hours. Now, what I tell everyone is this, I think, is a really useful kind of frame of reference, but there is tremendous individual variability when it comes to someone's progression through alcohol withdrawal. So if you have someone who has had seizures before, if you have someone who has had alcohol withdrawal delirium before, if they have a TBI, if they have an eating disorder, they are at higher risk of progressing to those dangerous outcomes earlier on in the process. So worry sooner and intervene more aggressively for those folks. So helpful timeline to keep in mind, but please adapt it to your patient. When it comes to actually figuring out the severity of withdrawal that someone is experiencing in front of you, the CIWA, I think, is a really helpful tool with some limitations. So this is the Clinical Institute Withdrawal Assessment. And as you can see, it kind of helps you score someone's withdrawal based on a number of clinical findings into mild, moderate, severe, or kind of complicated or complex withdrawal categories. And the cutoffs are there for you. And this is meant to be a tool, not the only tool, in kind of guiding what type of withdrawal management strategy you might consider. And I think it's really helpful and should be combined with a number of other considerations. So first of all, there are subjective elements to the CIWA. So you might see someone scored with a CIWA of 10, who then an hour later is scored with a CIWA of 5 without any intervention. And that might just be because of individual variability in scoring someone. So making sure that someone is being scored consistently by the same clinician who has been trained appropriately, I think is important. And we need to keep in mind there are subjective elements. On the other hand, vital signs are not a part of the CIWA, which is incredible because we're worried about autonomic instability. So look at your patient's heart rate, blood pressure, et cetera, as you're considering their level of withdrawal. This does not also account for the patient's individual history. So someone with a borderline CIWA who has a history of a seizure disorder, for example, might be particularly worrisome, and you might err on the side of treating their withdrawal more aggressively. So know the person's history and their risk factors. And this is kind of the biggest kind of takeaway, I think, which is that really the CIWA is a tool, but classifying someone's withdrawal risk is really, this is the art of medicine, right? So this is classification that is really up to you as the clinician and to your judgment. Speaking of some of the additional risk factors, so older folks, of course, can be at increased risk of poor outcomes related to withdrawal. Medical comorbidities, particularly heart disease, can increase the risk. Substance use that goes along with alcohol, so co-use of CNS depressants, so that includes benzodiazepines, maybe rarely barbiturates, certainly much more commonly opioids. Other substances that someone may be withdrawing from needs to be taken into account and also treated. Someone's comorbid psychiatric conditions, Dr. Peterkin mentioned this, but someone's comorbid PTSD, depression, psychosis, et cetera, may also be exacerbated during withdrawal or during intoxication and needs to be managed. And then masking symptoms. So sometimes the presence of another substance might mask the symptoms of alcohol withdrawal or the signs of alcohol withdrawal. So for example, someone who has opioids in their system might actually have their alcohol withdrawal symptoms somewhat masked by the opioids. So we need to be thoughtful about understanding the entirety of what someone has in their system. And finally, there's the kindling effect. And I think this is really helpful to keep in mind for ourselves, but also educate our patients about. And this refers to the fact that as people go through rounds of withdrawal recovery, the severity of the withdrawal symptoms goes up over time. So this is the kindling of the flame that happens over time. So going through this cycle again and again really takes a toll on the person, and we want to treat it early. Everyone, I think, has encountered the cage questions before, so I won't belabor this, except to say that the cage questions are still relevant and still really helpful as a screening tool. And they have actually been expanded to include drug use. So this is different from my time in training, but you can actually ask, have you ever felt you needed to cut down on your drinking or drug use, et cetera? And this has still been found if someone has one or more positive answer to be fairly sensitive and specific. I'm going to talk a little bit more about mutual support groups, even though Dr. Hurley covered these in great detail. So these are free community-based peer-led groups, as you may know. They can be 12-step or not, and then also increasingly online, which I think is something we really, or I at least, neglect to mention to enough of my patients, that there are so many virtual options. And there are a range of options from AA to Narcotics Anonymous to Crystal Meth Anonymous, CMA, et cetera. And then there are many subcategories of each, including LifeRing, which is a secular option, Smart Recovery, which is kind of more motivational enhancement and CBT based. And then there are tremendous kind of variations based on demographics, spiritual practices, et cetera. So I tell people to try out multiple groups to see what works for them. I tell providers to go to groups, go check these out. You know, many groups are open. Most groups are open to everyone. So I think it can be incredibly educational to go and experience it yourself. The 12 steps that Brian mentioned all touch upon different concepts, core concepts. In AA, these are all outlined in kind of the big book. And I think it's helpful to actually look at the steps and know some of the key concepts and ask your patient if they're working the steps, and if so, which step are they working on, which concept are they tackling at the time. We talked about motivational interviewing, and it has great evidence for alcohol use disorder, as it does for multiple substance use issues. And the important thing to remember, this is kind of a quotation from the originators of motivational interviewing, is that it really is a style of interview that is focused, somewhat similar to the example we saw, on strengthening someone's personal motivation for change and working towards a specific goal. So an MI-informed approach, including to medication prescribing, can be useful. Acceptance and commitment therapy, ACT, has, or ACT, has a lot of evidence. It also focuses on 6 core processes that I'll leave here for you to kind of peruse. And then I want to return, you know, in addition to having considered the behavioral management that might be helpful for a person in some of the other stages of addiction, particularly in the preoccupation anticipation stage, we want to think about detox management in that kind of withdrawal state really thoughtfully. And the mainstay, according to the ASAM guidelines from 2020, of withdrawal management still remains a GABAergic agent, so a benzodiazepine. Most commonly, you will see, and we will be using diazepam, lorazepam, or chlordiazepoxide. And then if someone has significant liver impairment, we might consider lorazepam, oxazepam, or temazepam, the lot drugs. So this, I think, is helpful for clinical practice. If you are a fellow or someone preparing for your board exams, that is a high yield fact to know that you may get tested on. Increasingly, we're trying to use benzo-sparing approaches. So we are often using gabapentin, valproic acid, or carbamazepine, either as adjuncts or as monotherapy in some cases with low-risk patients. We should always be giving people thiamine to prevent the progression to Wernicke-Korsakoff. And then refractory withdrawal is a huge problem. It often requires more highly sedating agents like phenobarbital, like propofol. These might be medications that you see at the ICU level of care. Going back to the preoccupation anticipation phase, which is what our patient was in the interview, there are 3 FDA-approved medications that you heard the doctor in the video mention. These are disulfiram, which has been around the longest, naltrexone more recently, acamprosate, and then the injected form of naltrexone, which is a monthly injection, approved most recently. So we should be offering these options to all of our patients. I am a fan of mnemonics or acronyms for remembering things. So I like DNA for disulfiram, naltrexone, and acamprosate. Please use that as you will. Disulfiram causes that acetaldehyde reaction, which is really aversive. Someone's goal really needs to be to remain abstinent in order to be on that medication. Naltrexone, available either as a pill or an injection, blocks mu opioid receptors and can be taken once daily or injected once a month. And this is compatible with someone's goal of abstinence or of cutting back. And then acamprosate 3 times a day modulates glutamatergic hyperactivity, can really help people in early recovery abstain or cut down kind of going forward. There are a couple of off-label medications that we use. So these are not FDA approved, but incredibly common. These include gabapentin, often at 600 TID or higher, and also topiramate. And I do think we need to practice some caution with topiramate around some of the, and I emphasize this, relative contraindications, not absolute contraindications, around renal failure, renal stones, narrow angle glaucoma, cognitive issues, paresthesias that can kind of come up. But overall, this has such a promising evidence behind it that actually the VA guidelines and the DoD guidelines recommend naltrexone and topiramate as first and second line at this point. So we should be thinking about it. And then I guess this is something that all specialists say, but I really believe is true here, which is please consult with a specialist. We are available to you to think about topiramate or baclofen or any of these kind of off-label options. And then in terms of kind of some of the longer term efficacy, this is a study that came out a couple of years ago in JAMA meta-analysis that looked at 118 studies, just about 21,000 participants. And what they found is that in conjunction with some psychosocial interventions that were standardized, oral naltrexone or acamprosate had pretty good evidence as first-line pharmacotherapies for alcohol use disorder. So the numbers needed to treat are actually up there and were kind of 11 or 18 respectively for acamprosate and for naltrexone to prevent a relapse to any drinking. And now I will say, I think we may have these reversed on the slide, but the takeaway remains the same. These are evidence-based medications. All of the medications FDA approved and off-label have a fair amount of evidence behind them at this point, and we should be considering certainly these, including the injected naltrexone and some of the other options I mentioned. And so I know that was kind of rapid fire, but I hope useful to you, and I'll leave you with my takeaways. Beyond kind of the diagnosis of alcohol use disorder, think about the stages of addiction. So that includes that intoxication, withdrawal, and preoccupation craving phase, and that can really help guide the immediate management. Think about the FDA-approved medications, DNA, right? And the off-label medications for every patient, right? And in my practice, when I'm working with trainees, when they present a case, I will often ask, which medication are you prescribing? And if you're not prescribing something, please tell me why. And I think I hold myself to that same standard, which is useful. Behavioral treatments, as have been mentioned by my colleagues, are incredibly helpful, both in the community and in the clinic. And finally, you are an addiction treatment provider, not because you're just here at this conference, but because you see patients at all. The vast majority of people with an addiction will never see someone like one of us, you know, a specialist. The vast majority of people will see a primary care doctor, a general psychiatrist, someone in a different field than we do. So each of us in medicine will be an addiction provider at some point. And I hope you leave a little bit more encouraged to continue that work. Okay, and we'll end with our final reflection question. So thinking back to some of the evidence supporting the use of medication-based therapies for AUD, are there any different options you would offer to your patients with AUD compared to what you do now? And I'll let you kind of reflect on that as we move on.
So the polling questions, we asked this at the beginning, we're asking again now. How confident are you in your ability to apply guideline-based pharmacotherapies when developing a comprehensive treatment plan for patients with AUD? 1, not confident at all. 5, very confident. And we'll give it a few moments. All right, we saw increased confidence. Excellent. How confident are you to apply guideline-based psychosocial interventions when developing a comprehensive treatment plan for patients with AUD? 1 being not confident at all, 5 being very confident. All right. Once again, increased confidence. Okay, so we already have more questions than time, but for the next few minutes, we'll be taking questions that were posed through the QR code or the online portal. And I'm actually going to start, Tahid, I'm going to direct this question to you. Sure. You talked about some off-label medications that were in the, I think it was a JAMA Review article, sort of meta-analysis. Can you comment at all around, there's a new class of medications, these GLP-1 receptor medications. What can we say at this point about the use of those medications and the evidence for AUD?
So I think the evidence is really emerging. There's great interest in GLP-1 agonists, I think in general. But with addiction, what we're seeing is actually with a number of different use disorders, including alcohol, lower rates in people who take GLP-1 agonists. I will say, I think that data is early. So the data have not or GLP-1 agonists, as far as I know, have not been looked at as an intervention in large RCTs, like double-blinded studies, kind of the gold standard, but there is emerging evidence. I will say I don't recommend it right now as a treatment, but in my patients who get put on one of those medications, I absolutely talk about that as a potential fringe benefit. I talk about monitoring their alcohol intake over time, along with some of the metabolic markers that they might be looking at, which overlap with alcohol use anyway. So I will say, I think of it kind of as right at this moment, an area that has emerging evidence, but where it's not kind of strong enough for me to recommend as a first or second line treatment.
I'm going to combine the next two questions. One is, how do we get, and Alyssa, I'll actually direct this to you. How do we get more screening in primary care? And can you comment on CAGE?
How do we get more screening? So we are definitely not doing enough screening. Options for improving screening, implementing in the EHR, so electronic medical record. So a lot of health systems already have those options. So being aware of that, including it in your note template so you don't forget to ask. Other options I think about when I go to my primary to check in, there's like an iPad at the door, and there are all these different screenings that I do, which is like, oh, I know what you're doing here, but I'm glad that you're doing this. So I think, not everything has to fall on us during the patient visit. There are things that can be done before we even see the patient that can help us make these necessary interventions if there is a positive screen and moving forward with diagnosis. And then commenting on the CAGE. So, I don't use the CAGE. I think some people have some challenges in terms of the way the questions are worded, but I do think with the new version, it includes, not just talking about alcohol, but other drug use. And as I said, there are other screening tools, and I'm biased for the single item question, right? In a time where we're so busy, we have so many competing priorities. Like if you can just ask one question and it can move you forward into the next steps of the care plan, that's sort of what my preference would be. But in med school, I learned about the CAGE, but then when I went to residency fellowship, I learned about all the other options and the evidence behind those as well.
Can you elaborate on your recommendation to avoid phone and social media while drinking?
There's a lot of, you might post something you don't want to post. You might say something that you don't want to say. And so I think there's a lot of danger in that, right? You could be posting your location that maybe other people don't need to know about. There are a lot of sort of safety risks with that. So that is a lot of what I think about, especially if you're intoxicated. You might be making decisions that you would not normally make when you are not under the influence of drugs and alcohol. So for me, it's more so a safety reason, because you might be doing things impulsively that you would regret the next morning or, whatever you have sobered up. So that's my thought on social media and alcohol use.
Thank you. A question came through. What if you have a patient who previously was abstinent with respect to alcohol? They were abstinent for many years. They identify as sober. They relapse and they want to get sober again. And those are the words they use. I'm an alcoholic. I was sober and I want to get sober again. How does the approach around sort of using terms shift in that instance? Well, I'd say in that instance, you use the terms that the patient feels most comfortable with. So it's not wrong to use terms as long as you and the patient are aligned about what they mean. What I see happen is we introduce terms before we have any awareness of who we're talking to and how those terms are going to land. So I don't want anyone to walk away thinking there are terms you can't ever use, but you have to use them intentionally, understanding the context. On the other side of it, how do you respond to somebody who's in and out of treatment all the time? Well, one thing is, if somebody is in and out of, I don't know, say a residential treatment program all the time, actually maybe connecting them to a lower level of care that they can stay in touch with, even if they're not ready to stop using, might be appropriate. That is to say, ironically, that might be a level because they're just sort of not ready for. And we are better focusing on engagement than we are around making somebody do everything that we would want them to do before they're ready. Any of you have any thoughts around working with somebody who might be in and out of treatment and what to do?
I mean, just acknowledging the success. I mean, being in and out of treatment is better than not being in treatment at all. So I think we do need to focus on engagement. The other thing is we really need to think about low barrier access. I think that some of the thresholds to actually get into treatment can be quite high. Those can be economic barriers. Those can be requirements around sobriety, kind of other factors. So I think maybe kind of, first of all, acknowledging the successes. Secondly, maybe trying to address the barriers and kind of staying engaged and being kind of thoughtful broadly about what those might be for each individual patients can be a helpful approach.
One question that came up is, are there any good methods of talking to people who might not be ready to change? Motivational enhancement therapy, which is the manualized version of motivational interviewing, would be my best recommendation to start. And how does this change if somebody is licensed as a nurse, doctor, or pilot? I would say in an instance where you're working with somebody whose license is contingent upon them having a different or terminated relationship with a substance, you would just be clear about that with them, right? Like that's part of their consideration. But keep in mind, they may choose the substance over their license, and that is a choice that they can make, right? You would want to be transparent about that, right? As a clinician, I wouldn't want to shy away from that fact. So in other words, I would include that in the information that I would consider in talking to somebody about themselves and the role that their professional role and how they see their lives. But I'm not necessarily going to make my relationship with them contingent upon their abstinence if that's not something they're ready to do. All right. We are a few minutes over time. I really appreciate everyone's time and attention. Thank you so much for participating. To earn your credit, please scan the QR code here or click on the Earn Credit icon. Thank you so much, everybody, for your time and attention. Take care.